Hello, everyone, and thank you for joining us today for our Lunch and Learn webinar series. Today's session is titled Maine Lung Cancer Coalition, Working Together to Reduce Lung Cancer in Maine. Your audio is available through your computer speakers, but you can also connect using your phone. The phone number is listed here on the screen, and it's also in the registration email you received. We're just going to do a little housekeeping before we get started with our presentation. First, I want to talk a little bit about Maine Quality Counts. We are a member-driven nonprofit organization located in Manchester, Maine, and we are working to improve the health of all Maine people and beyond by transforming the way healthcare is delivered. Our strategic priorities are to bring people together who give, get, and pay for healthcare services to address these priorities, to improve the alignment of healthcare systems to transform health for all Maine people, to provide quality improvement assistance to practices, to engage consumers in healthcare, and to promote the integration of physical and behavioral health. There are a number of ways to connect with us. You can join our mailing list, and you can also read about the latest events and happenings by going to our blog. And then there are a number of social media platforms that you can follow along, including Facebook, Twitter, and a number of other platforms. This webinar is made possible with support from our QC members, and you can learn more about becoming a member by visiting our website and clicking on membership. The benefits of being a member include networking events and newsletters, webinars with national experts, and a discounted registration to our annual conference. Some important notes about the webinar. You are in a listen-only mode. Please use the Q&A function to ask questions and or make comments. We will be monitoring the QA throughout the webinar, and there will be 10 to 15 minutes at the end where we will open things up for questions. You can adjust the video size screen and locate it to a more convenient place on your computer. Tomorrow, you will receive an email with the link to the recording along with the presentation slides. And then this webinar recording will be archived on our Lunch and Learn webpage, and you can watch the recording at a later date or share it with your colleagues who are not able to attend. So at this point, I'm going to turn things over to our presenters who will now introduce themselves.
So hi everyone, this is an honor to be able to present today, and I want to thank Maine Quality Counts for giving us the opportunity. My name is Paul Hahn. I'm the director of the Center for Outcomes Research and Evaluation at Maine Medical Center and the co-principal investigator of the Maine Lung Cancer Coalition. And you're going to be hearing about this initiative today.
And this is Natalie Morse, and I'm the director of the Prevention Center at Maine General Medical Center, and I am one of the co-leagues for the prevention component of this project.
Hi everyone, my name is Jessica Reed. I'm the Quality Improvement Manager here at Maine Quality Counts, and one of the co-leads for the stakeholder engagement core here for the Maine Lung Cancer Coalition, so you'll hear more about that later.
Hi, this is Kathleen Fairfield. Thank you for having me. I'm a physician scientist here at the Center for Outcomes Research and Evaluation, and I lead the data analytic team.
Hi, everyone. My name is Leo Waterston. I'm the program manager for the Center for Outcomes Research and Evaluation, and I serve as the project director for the Maine Lung Cancer Coalition.
And we have one more presenter who's going to be joining us shortly, and we'll have him introduce himself when he's able to join in. And at this point, I'm going to stop sharing my screen and have Jessica share her screen and begin the presentation.
There we go. Great. So welcome everyone. Again, we are so happy that you've taken the time to join us today, and we hope that you find this webinar full of a lot of rich information. You know, the Maine Lung Cancer Coalition we're excited to share this work with you, explain really what this is, and hopefully, you know, if you'd like to help support us in this effort, you know, that is really the intent as well. So we are really excited to make a difference, and truly the title is really what we are hoping to do, and that is to work together across the state. So please keep that in mind as we're presenting today, that this really is a statewide initiative, and we really want to work together to reduce lung cancer in Maine. So again, we're so excited you're here with us today. today. And I'm going to turn it over now to Dr. Paul Hahn. Again, as he said, he's the director for the Center of Outcomes Evaluation for Maine Medical Center and the lead PI investigator for this grant, this coalition. So I'm going to turn it over to him to start us off. So.
Great. Thank you, Jessica. And thanks once again to Maine Quality Counts for sponsoring this webinar today. So I'm going to talk to you about this initiative called the Maine Lung Cancer Coalition, and to give you a sense of what the coalition is and what the goals are, and also how we can work together to tackle this problem of lung cancer in Maine. Next slide, please. You have to click on the screen. Okay, so just to begin the talk, we and me and my colleagues here, we have no financial relationships with commercial entities that could pose a conflict of interest. So the objectives of this webinar are threefold. Number one, to understand the extent of the lung cancer problem in Maine. This is a topic actually that I think most of you who are listening have a sense of the magnitude of this problem, but we're going to give you a little bit of data to help put this problem into context. Secondly, to understand the promises and challenges of implementing evidence-based strategies to prevent and screen for lung cancer. And then overall, to become familiar with the goals, activities, and the partner organizations of the Maine Lung Cancer Coalition. So the Maine Lung Cancer Coalition is a 4-year initiative devoted to reducing the burden of lung cancer in Maine. That's kind of the highest level goal of the whole initiative. And we're going to drill down on exactly how we're going to be doing that. This is a multi-institutional collaborative partnership of healthcare institutions throughout the state of Maine. And that's really another overarching goal of this initiative is to really reach the entire state and to involve as many stakeholders and healthcare providers as we can. The central areas of focus of this initiative are prevention, early detection, and also health inequities, and specifically in our state, as we know, rural-urban healthcare disparities. So we're very interested in improving access to care to rural underserved populations at high risk of lung cancer. The two goals that we have that are really driving this work are, number one, to engage and educate a broad array of stakeholders, including the general public, patients, healthcare providers, payers, and policymakers about evidence-based lung cancer prevention and screening services. And then secondly, to innovate and evaluate strategies that are community-based to increase access to evidence-based prevention screening and also treatment services to the entire Maine population, again, focusing on high-risk individuals in rural underserved areas. This initiative is funded, and we're very grateful for this funding, by the Bristol Myers Squibb Foundation and also the Maine Cancer Foundation and the Maine Economic Improvement Fund. You can see there are several partners in this effort. This slide actually doesn't encompass all the partners because thankfully we have a growing list of organizations and individuals throughout the state that are signing on to this initiative. But these are some of the main partners that have been involved from the get-go in this important initiative. So why does this initiative exist, and what is the reason for this whole program of work? The problem is that lung cancer in Maine is a huge issue. It's a high burden. It's really a condition that's responsible for a great deal of suffering and death in our state. It's the third most common malignancy in Maine, and it's the leading cause of cancer mortality, deaths from cancer in Maine. About 75% of cases that are diagnosed of lung cancer in our state are at the late stage. So in other words, we're diagnosing disease late at a point where people cannot be cured and where the disease can't be managed. In Maine, if you look across the country, we have the 6th highest incidence of lung cancer and the 12th highest lung cancer mortality in the country. Tobacco use, as we all know, is a big problem in Maine as well. Our state has the third highest prevalence of people who have ever smoked and the 11th highest prevalence of current smokers in the US. And we are the highest among New England states, and especially in rural areas in our state. And then as many of you know, we also have a particularly big problem with radon, environmental risk factors in this state, as well as arsenic, which is a risk factor not only for lung cancer, but many other malignancies. But then one problem of, I think, particular interest in our state is these geographic and sociodemographic inequalities in our state. And these contribute uniquely to the burden of lung cancer in Maine. And to give us a little bit more background about how these geographic and sociodemographic disparities contribute to the lung cancer burden in Maine, I'm going to turn the presentation over now to Dr. Kathleen Fairfield, who works with me at Maine Medical Center, and she's the head of the data analytic team of this initiative. So Kathleen's going to give you all a little bit more detailed background about the burden of lung cancer in Maine, and specifically focusing on geographic and sociodemographic disparities in lung cancer.
Okay, thank you, Paul. I'd first like to acknowledge our team. We have two outstanding analysts, Adam Black and Kim Murray, and senior epidemiologist Lee Lucas, who are all part of this excellent team. Next slide, please. This slide shows the lung cancer incidence for Maine and the United States. You can see that the age-adjusted incidence rate for Maine is higher than the US, as Paul was just saying. Our absolute annual counts average around 1,300 to 1,400, and the trend in the US overall is that lung cancer incidence is falling very slightly, but that in Maine it's stable and it's not falling. Next slide. These data are from the same source, so this comes from the Centers for Disease Control and National Cancer Institute. And over to the right, you'll see that the key, and it shows the exact same numbers, so the US rate and the Maine rate are given there. And then there's a color key for county level incidence rates by quartiles. And this is, counties are a rough way to evaluate cancer incidence, but you can see wide variation in lung cancer incidence with some very high incidence rates in certain counties. Next slide. So our team uses data from a variety of sources to better understand these relationships between geography, risk factors, and healthcare delivery and lung cancer incidence and outcomes. Our source for health behaviors are the behavioral risk factor surveillance system that are gathered by the Centers for Disease Control and administered through the state. So we have the Maine data with zip code, with mortality data from Maine death certificates that also includes zip code. We have lung cancer incidence and stage from the Maine Cancer Registry. And lastly, treatment patterns from an all-payer data set gathered by the Maine Health Data Organization that allows us to look at surgery and chemotherapy and radiation. Next slide. So again, this work is going to examine geographic variation across the state as a way to get context for some of the work that's happening in this coalition. You mentioned the BRFIS data, death certificate data, and I'll also add that we're using census data for poverty and looking at low education as risk factors. Instead of using county level data, we're aggregating to something called the hospital service area. Those were defined by the Dartmouth Atlas team a number of years ago, and it's a way to understand healthcare delivery systems for local care. In general, there are 31 hospital service areas in Maine, and in general, these correspond to a single hospital. But in 3 areas, Bangor, Lewiston, and Portland, there are 2 hospitals in the hospital service area. Patients are assigned to the hospital service area where they live and not where they get their care necessarily, although we are now establishing methods to look at where people get care delivery. Next slide, please. This simple graphic demonstrates the burden of lung cancer over these 4 years that we have data for Maine. It looks like it's dipping, but statistically the rates of lung cancer incidence have been stable over these years. Next slide. So now we can begin to look at data at the hospital service area level. And this graphic shows side-by-side lung cancer mortality and current smoking rates for the years that we had data. You begin to see patterns that don't correspond exactly, but there are areas along the coast, for example, that have lower smoking rates and lower age-adjusted standard lung cancer mortality ratio compared to the state. This begins to inform our prevention and screening efforts as well. Next slide, please. These side-by-side graphics show the percent without a high school degree and the percent living in poverty for the state at the hospital service area level. And similarly, you can see kind of a healthy coast effect in some areas of the state that have very high incidence of low education and poverty. Those are very tightly correlated, as I'll show you in a moment. Next slide, please. This is a correlation matrix demonstrating these relationships between lung cancer mortality from the tumor registry data and then smoking, poverty, and education. And it won't surprise you to see that poverty and low education are highly correlated, as are smoking and poverty and education. But lung cancer mortality is also correlated with smoking, as we know it's a major risk factor, but poverty and education, starting to point to some of the disparities in that give rise to differences in incidence and then outcomes when people do get diagnosed with lung cancer. Next slide, please. Our observations, therefore, include the fact that there is substantial small area geographic variation in mortality and the risk factors, smoking, as well as some of the socio-demographic characteristics in our state. We also see that there are significant associations between mortality, smoking, education, and poverty. And I didn't show you lung cancer surgery data because of those are preliminary, but we're seeing variation in the type of surgery performed according to the hospital service area where people live. And that's an additional area that we're starting to explore. Next slide, please. Oh, sorry. Our work going forward then will be to continue to work with the tumor registry to look at differences in incidence rates at the hospital service area level and also in stage of diagnosis. This will particularly be important as we start to look at opportunities for screening programs and partnering with local organizations for that work. We're going to be able to monitor incidence and stage of diagnosis using these tools as this work with the coalition continues. And that'll be part of our evaluation. We also want to be able to understand virality and stage diagnosis and timeliness of treatment, including surgery, chemotherapy, and radiation. And all of this work will inform the work on prevention, screening, and treatment. Yeah. That's it for me.
Great, thank you, Kathleen. And that was an excellent overview of the magnitude of the problem of lung cancer in Maine. Some of the take-home messages that you could see in the data that Dr. Fairfield presented were that clearly there's a high burden of lung cancer in Maine, and yet that burden is not equally distributed. Those geographic disparities that we see they correlate highly with health behaviors, sort of preventable or modifiable risk factors like smoking in particular. And the data also point to the need to really focus on these areas of the state, these communities where the burden of lung cancer is particularly high and where we can do something about that. And so that's really the gist of why this coalition exists. We feel that there are many areas that we could work together to intervene upon and to reduce the burden of lung cancer in our state. Next slide. So we've got a sense of the problem, in other words, of lung cancer in Maine, and this is the beginning, at least, the beginning of a solution that we've come up with through this idea of a coalition. The idea is that we can solve this problem by collaboration, by joining forces, by having institutions and healthcare providers and stakeholders, patients, patient advocacy groups, etc., really work together to tackle this problem mutually through collaboration. The idea also is that there's a lot of resources and expertise that already exists in our state. And yet, in different health systems and through different healthcare providers, historically, these resources have not been put together, and people have not been really working together in a collaborative manner. And so a big goal of this coalition is to really change that and to see if we can just work together and kind of cross institutional boundaries and cross disciplinary boundaries to really join forces to try to really get control of the problem of lung cancer in this state. There's a lot of knowledge and learning out there. There's evidence-based strategies that can be used to prevent and screen for lung cancer. And these are the types of things we want to work on together to make sure that those evidence-based practices are disseminated. And then ultimately, what we'd like to do is to strengthen healthcare systems locally and regionally throughout our state to be able to help disseminate these practices, and hopefully that we can work across those systems to share knowledge so that we're delivering the best care, the most evidence-based care that we can. So this is a pretty busy slide. It's a logic model of the Maine Lung Cancer Coalition. And I'm just going to kind of guide you through this. And again, these slides are actually going to be available, made available to you. But this is really going to give you an overview of what the coalition is in terms of its structure and what our goals are. And up here at the top of the slide, this is sort of the 30,000-foot goal we're trying to get at: evidence-based care, improved patient access, and ultimately improved outcomes. And we're doing this on a statewide system level. We're trying to engage with many different stakeholders here, ranging from healthcare providers to health insurance providers, or the payers of healthcare. And then we have these kind of four main goals: to build capacity of health systems to really improve lung cancer outcomes, to expand access to care, particularly in rural, underserved, high-risk areas, to engage multiple stakeholders, including patients, and to promote evidence-based practice. We have organized our work, and then really among three different cores that I'll talk to you in a second. But the two goals that I mentioned before here are innovation and evaluation, and then engagement and education of stakeholders. And to do that, we've kind of divided this Maine Lung Cancer Coalition according to three main kind of content or focus areas that you're going to hear about in a second from my colleagues. Number one, prevention. So these are activities all geared at improving lung cancer prevention. Early detection. These are all activities focused around improving early detection of lung cancer. And then stakeholder engagement and education. And what we're going to do in a moment is let you hear from the leaders of these three cores. Again, these are our structural kind of divisions that we've created to do the work of this project. You're going to hear from the leaders of these three cores about the specific work activities that, again, get to these two goals: innovation and evaluation, engagement and education, towards these higher level ultimate goals of the coalition. So this is the leadership team. It takes a village to do anything of this magnitude and importance, and there are also many other people who are involved and play active roles in this project, but these are the primary leads of those cores that I just talked to you about. And then we also have an advisory board of multiple stakeholders ranging from government to healthcare payers to patient advocates, and they are providing guidance to us on the overall strategic direction of this coalition. And so now I'm going to turn over the presentation to Natalie Morse, who is one of the co-leads of the Prevention Core, and she's going to talk to you about some of the specific activities that the Prevention Core of this coalition is engaged in.
Slide. This just explains where she is.
So this is the Prevention Core. So Barbara Perry with the Center for Tobacco Independence and I are the co-leads on the Prevention Corps. I'm going to talk a little bit about, at a very high level, some of our work. We are focused on looking at some of the environmental health aspects of lung cancer. And Paul mentioned a little bit about this earlier in the presentation, that includes radon and arsenic are some of the environmental factors, as well as exposure to tobacco smoke and then other types of pollutants. We are working as a group to really look at what is out there related to health messaging to people in the community about environmental health risks for lung cancer. And we have an advisory team that has been created to do this work. And we also, in the process of that, have been pulling together some stakeholders that are really interested in policy as well. And that is all getting woven together. Again, these cores of this work are not silos, but there's really a lot of connections back and forth between those things. One of the key things that the Prevention Corps is working on right now in the first year has been message development. And we've been out working in the low-income communities. Primarily, we've been focused on Kennebec and Somerset County. And if you remember going back to those colored slides, those are some of the areas with those dark colors where there's high percentages of people with, they've not completed high school and they live in poverty. And in fact, there's 18 census tract areas in Kennebec and Somerset County where that is true, where 30% or more of the people 25 and over meet that criteria. And so we've been really focusing our efforts in those areas. We have a team of a community health worker and a project assistant have been going out and talking to individuals about their knowledge of lung cancer and lung cancer risks. We've been, the last few weeks, out with messaging. So we've looked at what are some of the existing public health messaging that the Center of Disease Control that Lung Association has, that the Center for Tobacco Independence has around tobacco, radon, arsenic. And we've been testing those messages. And we're getting some really interesting feedback from these high priority populations that we need to be reaching out to engage them in lung cancer risk reduction. The advisory group that we have really is, again, a lot of the people from the other corps, as well as people working in the traditional public health and prevention world. Another component of our prevention work is taking the messaging that we're working on and the use of community health workers into primary care settings, which should be of interest to a lot of you today. We actually have selected 4 primary care practices within Maine General Health that have agreed to be part of this pilot project, where we're going to actually be doing work with the practices proactively referring patients to community health workers for outreach purposes and using the messaging. And this is more of a population health approach where we'll be the practices will be running reports, looking at all of their current and former smokers, identifying which of those patients they would like the community health worker to outreach to, and then having those community health workers use the messaging that we've developed from the advisory process. Next slide. So the community health workers, if you have not heard a lot about the use of community health workers, we've been using them really for the last 4 years at Maine General in a variety of our projects. They've been highly successful in our colorectal cancer screening work. We've been able to increase colon cancer screening rates to 80% in the practices that have been using them. So we're going to use a similar model where the community health workers will be armed with a risk reduction messages, and they will be working with those primary care practices to have conversations with patients and really sort of helping address the barriers and learning about the barriers for these low-income communities. We know that in our other work, it has been things like transportation, cultural concerns. Some people have told us that they don't even want to know if they have lung cancer because they don't feel they have the ability because of all the other things in their lives to deal with that. So those are some of the things that we're going to be learning about and collecting data about in this community health worker pilot model. Another major part of this project is the tobacco cessation work and working with CTI. CTI is prepared to do a lot of training of primary care providers around brief intervention, how to provide tobacco cessation counseling in primary care. They are working with our community health worker team to actually help them do brief intervention and support. And they are going to be really beefing up the tobacco treatment training across the state, specifically to help us reach those high-risk patient populations in rural areas. I mean, the Maine Tobacco Helpline is really a great resource that we have in here, Maine. It's not being well utilized, and especially in rural areas. So a lot of those low-income folks are not really aware about the helpline. It's really interesting in talking to patients about that. And we hope that this prevention work will really help us kind of get to the root cause about why people aren't utilizing that service as much, and really trying to get providers in the practices referring more patients to the Maine Tobacco Helpline for the support that they need. And now Jessica.
Hello, everyone. It's great to be with you all today. This is, again, that high-level slide that Paul showed in the beginning, and I showed that just before Natalie spoke as well, just to kind of show where we are, you know, in this logic model, so that you can kind of see where we fit in as we're talking today. So really the two big buckets for the stakeholder engagement and education core. I'm one of the co-leads along with Lee Gilman. She is the director for the American Lung Association New England division. And so our really big pieces are to develop and implement education and outreach strategies, and then also looking at and I'll get into the details on this in a second, really looking at what are the needs and barriers that we're seeing out in the community, and looking at prevention and screening services for at-risk rural populations. So within this core, we have different members that all work on different projects, and then we get together, and like Natalie said, please keep in mind as we're talking about this that these cores overlap. So you'll be able to see this as we move along and how these all interrelate to each other, because truly the work of one influences the work of the other. And so, you know, again, keep that in mind as we're talking. So within the USM division, we have a project that we have here with USM and looking at a vulnerable population demo. And so what they're doing, it's a complete IRB research process, and they're looking at identifying individuals who are at risk for lung cancer, who are really disengaged, and that is a key word. They are really disengaged from the healthcare system, and really looking at why is that, and what are the beliefs, what are their barriers, you know, really addressing that with the focus around lung cancer screening. So they are putting together focus group. One, I believe, has taken place last month. They had one last month, and really, you know, they're finding it just fascinating talking with these individuals as to, you know, what is their kind of knowledge level about lung cancer screening? Do they, you know, really all kinds of topics and questions that they ask them in these focus groups that we're going to use then to influence this work. The other piece folds in community outreach. So really, again, looking at rural health, looking at Maine as a state, and how do we really look at engaging community coalitions to really help with this effort. You know, really the idea, again, with this statewide project is we want to engage and really use the resources that we have, and how can we do that to the best of that concept, so that we can really use that to really influence lung cancer screening and reduce that burden in Maine. And then the Maine Lung Cancer Coalition Summit, so that is the lead organization on that is Lee Gilman and her staff, and that is, again, the American Lung Cancer Association of, the American Lung Association of New England. And so what they're doing is we had our first meeting in May, and Dr. Neil Corson's going to speak a little bit about that in the webinar at the end. But really, the whole intent for that is really to bring together key stakeholders to assess the current status and really look at a consensus on what needs to be done and where things are at in lung cancer screening right now in Maine, and then really create this really strong, engaged network of stakeholders to really focus on improving lung cancer screening rates in the state of Maine. Another piece that the American Lung Association focuses on within this grant too is around policy. There is right now in the legislature, a legislative document number 720, and that is really looking at, that's been introduced, an act to provide lung cancer screening for Maine care recipients. So that is in the legislation as we speak, as we speak. And if you want any more information on really the in-depth pieces of that, we're happy to connect you directly to Lee and her staff to be able to answer your questions on that. The provider outreach and education, that is where I fit into this core group, and really that is really developing, again, statewide education. This webinar is the beginning of this whole process, and there'll be a whole webinar series to come that we hope will really educate you. And so basically taking all this work that we're doing and really putting this into webinars and learning modules to really be able to help you with your patients, and with really giving them that lung cancer screening guidance, I should say, throughout the whole process. So again, looking at this statewide education program for clinicians and clinical staff on evidence-based lung cancer screening and prevention. And you can again start to see where these cores overlap. Looking at tools and resources, again, like what Natalie's group is doing, how do we then transfer that into practice? And then in years 3 and 4, looking at a learning collaborative. So again, taking all this work and recruiting practices to really take a deep dive into this and really look at workflows, really using quality improvement methodology to really engage, clinicians, staff, really the whole practice within lung cancer screening. And then the other component that I am also working with is the patient, family, and advisory group. So we're pulling together basically to really have that patient voice that we all know is so very important to any of this work. So that is in the process now of just gathering that group together and really, again, using them again, like for Natalie's messaging, the different things that we have to get their voice, which is, I feel the most important one of all. So that's all of that work. So I'll turn this now over to Dr. Corson. And Dr. Corson, I'll just have you introduce yourself. And I know that you joined us a little bit late, but we're so happy to have you. And I'll hand this now off to you.
Thank you, Jessica. Hello, everybody. My background is I was a family doctor and geriatrician in rural Maine for almost 20 years. I now work at Maine Medical Center at the Center for Outcomes Research, and I have the good fortune and pleasure to be part of the group leading the efforts on early detection, partnered with Paul as the co-leads on that. Next slide, please. So you've seen this one before, and the 2 primary things that the early detection core is working on is to first define in the sense of there are a number of guidelines for how lung cancer screening should be done, who the priority population is. Across different organizations, they're more similar than different, but they still differ enough that what we hope to do is to come to some consensus across the state in terms of what we think the best evidence-based approaches are, and then to spread those evidence-based approaches as widely as possible, using the stakeholder education and engagement core to help us. So that's where, as others have said, there's overlap. We are also doing a couple of pilots to look at best ways, especially to reach the difficult to reach populations in rural Maine, one using telemedicine, the other using navigation to help make sure that people are not lost to follow-up in this process. So I'll talk a little bit more detail about our activities. Next slide, please. Thank you. So as you can see, and as we're starting today, lung cancer screening is a relatively new process. The large study called the National Lung Screening Trial that is the evidence base for screening was only published in 2011. The U.S. Preventive Services Task Force only endorsed lung cancer screening as a recommended preventive service in 2013. Many of you in the audience probably know the statistic that from development of evidence to implementation in practice of new evidence-based approaches usually takes 15 to 17 years. We're hoping to do it in less, and that's why 4 years after the recommendation, we're working hard on getting the word out to people about lung cancer screening. We want patients who are at risk to be aware. We also want the providers, primary care and specialists who might interact with these patients to know about lung cancer screening. As I mentioned before, there are a number of different guidelines out there from different organizations. That's not uncommon. They're more similar than different. However, there's enough differences that we think it would be valuable if we could come to consensus across the state. We're looking at coming to consensus on eligibility, on how we assess tobacco use, on how we do shared decision-making, what kinds of tools we recommend, how we follow up abnormalities, et cetera, et cetera. And the summit that was mentioned by Jessica, that I'll tell you a little bit more about in a moment, is one mechanism we're using to do that. Next slide, please. This slide goes into a little more detail about our two pilots, both of which we're working at this point to get up and running. The Nurse Navigator pilot, what we are learning across the state is many programs use nurses or other members of the staff to keep track of patients who are due for, who at least are eligible for screening, those who've had screening, to make sure that the results get to the right place, that those who need follow-up get the follow-up they need. And then, because this is recommended as an annual screening test, we want to make sure that we keep track of people over time and let people know when it's time to be rescreened. Navigation seems to be a good way to do that. A lot of people are using it. We will design a pilot to learn more about the navigation process and the impact of that. The pilot that is almost ready to go also relates to the fact that we're trying to reach rural populations that are not well connected to the healthcare system. So we're thinking that being able to reach out to them using telemedicine to address some of the issues of transportation and isolation in rural Maine. We're working with two practices, and we're going to be offering patients from those practices the option of having one of the required components of lung cancer screening, which is to have a visit before the screening to help the patients understand the pros and cons of lung cancer screening, to talk to them about tobacco and the impact of tobacco on lung cancer, and to help make sure that patients who are screened understand both the benefits and the risks using a shared decision-making approach. We're going to try doing that using telemedicine rather than face-to-face visits. We're going to see if it's feasible. We're going to look at the technical challenges, and we're going to see if patients find it to be equivalent of a face-to-face visit. So that pilot should be up and running over the summer in the practices that are going to work with us on that. Next slide, please. I want to tell you in a little more detail about the Lung Cancer Coalition Summit. This was a planned event by the American Lung Association chapter. We partnered with them, and just a month ago, more than 70 people from across the state, representing more than 30 organizations, including 16 hospitals that either were already engaged in lung cancer screening using the low-dose CT scan, or were thinking about and planning for a screening program, all got together. Some of the more established, experienced programs talked about how they're doing their work, what's gone well, what's been challenging. We had a colleague from the Maine CDC talk about a recent survey of hospitals across the state to see what's going on with lung cancer screening. We then did some brainstorming to figure out how we could move forward together, because our goal is not to have a single summit and then go off and continue to work on our own. But by bringing this group of people together, we want to stay together so we can work on all the components of the screening program, learn from each other, share best practices, and have all of us do a better job as a result. There was strong support for that idea, and we're in the process of planning the first follow-up meeting, which will probably happen in the fall. So there's great opportunity, because we're all coming together, to make sure that everybody's doing a high-quality approach to lung cancer screening. One of my memories from the summit that has been very encouraging is that during a break we took in the middle of the summit, I saw the leaders of the lung cancer screening programs from Eastern Maine, Central Maine, and Maine Health all standing together, talking with each other. I think that's a good example of what we're hoping to accomplish. So that's what we're working on in the early detection core. I will turn it back to our friends in Augusta for the remainder of the webinar.
Thank you, Neil. And I want to thank both Neil and Jessica and Natalie and Kathleen for giving us a great overview, kind of bird's eye picture of the Maine Lung Cancer Coalition. We could go on all day and really drill down in more detail about all the great work that is going on. But, you know, this presentation is really mainly meant to give you all a feel for the kind of work that's going on and the goals of the initiative, and hopefully to whet your appetite to joining us and being part of this coalition. And you know, we've talked about this coalition as one solution to the problem of the high burden of lung cancer in Maine, but I think you've seen that this work really depends on our collaborative work together, and we want to have a statewide reach. We want this to be a truly statewide coalition where we're really putting the health of our patients first. So we want people to kind of go beyond their silos of influence and sort of daily activity, and to really try to work together and stretch together so that we can put the health of our patients first. And so we have planned over the next 3 years extensions of the work that you've just heard about, one of which is going to be an extension of this very webinar series that we're participating in today. And we have some thoughts about some other topics that are focused both on lung cancer prevention and early detection. Dr. Corson just mentioned how complex lung cancer screening is, with multiple different steps ranging from determining eligibility of a person for screening to shared decision making, to the actual scan, to interpretation of the scan, to follow up with the scan, etc. That's a lot of steps that make lung cancer screening in particular very complicated and challenging. And so we're going to focus on that, those processes and many other things in upcoming webinars that Quality Counts is going to be working with us to implement in the future, as well as putting forth many other activities that the other presenters told you about. So I think at this point we wanted to leave, we have about 10 minutes or so for questions, and we really wanted to open it up to you all as a listening audience, and all of us here on the team would be happy to answer any questions that you have.
So we have 4 questions already in the queue. The first one is for Natalie. Could you please define what CTI stands for?
That's for the Center for Tobacco Independence.
Okay, thank you. Another question is, does Medicare pay for lung cancer screening?
Yes, they do, and I can let Dr. Corson and my other colleagues comment on this as well, but they have set criteria. So a person needs to meet the eligibility criteria for lung cancer screening. So basically they need, these are published, but they need to be between the ages of 55 and 77. They need to have a 30-year pack year smoking history, If they quit, it can have been less than 15 years ago. So there's sort of established criteria where Medicare will cover lung cancer screening, and most commercial payers are also covering it as well.
Great, thank you. And the next question I have is, do you have any data about the approximate percentage of lung cancer caused by smoking versus other factors?
That's a good question. That kind of data exists on a national level. We haven't looked at that on a statewide level, but I'm not familiar. I couldn't quote you the statistics on that. I'll maybe open that up to my colleagues, Dr. Fairfield or others, if you can comment on that. I'm personally not aware. I don't know that exact number.
This is Neil, and my recollection is that at least the estimate that's used is about 80% of lung cancer is directly related to tobacco use, and it's the typical 80-20 rule, isn't it? 20% is due to factors other than tobacco. And you're nodding, which makes me think that might be right.
Sounds right.
The next question that I have is, what screening tool do you use?
So the screening tool is low-dose CT. That's basically a special kind of CT or CAT scan protocol that uses a lower dose of dye, intravenous contrast dye, than a conventional CT scan of the chest that's done for diagnostic purposes. And it's a special protocol that, I would add, needs to be done by people who are trained in administering that protocol and also in interpreting the scan. So this is not the kind of scan that just sort of anybody can do anywhere. So it requires special training and certification. But really, the National Lung Screening Trial that Dr. Corson mentioned was a landmark study involving tens of thousands of patients around the country that showed that annual use of low-dose CT scans actually reduces deaths from lung cancer. It's the first time that any screening test has been shown to reduce lung cancer mortality.
I have actually several more questions keep coming in. The next one is, are you using random assignment of participants to determine the efficacy of early screening as well as prevention strategies?
I'll let Neil comment on that because I think, so that question is really focused, I think, on our pilot projects, but Neil, do you want to comment on that?
Yes, I will. So the randomized trial that showed that low-dose CT scan is an effective way to screen for and detect lung cancer early was a randomized trial with 50,000 patients. So there's, we think, no need to further prove that low-dose CT scan is effective. The pilots that I described are small-scale pilots to do some beginning proof of concept work on the use of telemedicine and the use of navigation. So randomization is complicated and expensive, and for what we need to learn, we won't be doing random assignment. These pilots may then lead to larger studies that might be randomized to test, to further test some of these concepts.
Great. Does any of this work involve the tribal populations in Maine?
So the answer to that is no. Although we are, I want to say, very interested in extending our work to tribal populations as well as other rural underserved populations of the state. As I mentioned, a primary focus of this initiative is on underserved populations and eliminating health inequities. And we would love it if we could have collaborators who are working with tribal communities, because we know that that's a high-risk population. So if anyone who's listening has any connections and would like to collaborate, that's something we would really love.
This is several comments and then a question, so let me just read the whole thing through. What is the public health role in this initiative? In the Down East Public Health District, we have a few partners collaborating on a cancer navigation pilot in order to be the coordinating link between the patient and the primary care provider. And the Cancer Treatment Center. We're also looking at lung cancer outreach based on the new screening guidance about lifelong tobacco smoker. Down East has known high rates of arsenic and assumed high rates of radon, so we're very interested in an outreach through housing upgrades and realtor outreach on radon testing. How do we align with your work?
Want me to address some of this? So some of what you're describing is exactly what we're working on in the prevention core. We are looking at those environmental health factors and then identifying those individuals who've been smoking throughout their whole lifetime and how do you link them to the services. So I would say get in touch with us and we would be very happy to sort of talk with you about what we're doing, what we're finding. And for example, some of the messaging work that we're doing right now and piloting is something that we would love to have you actually try using in your area to see if that works in other parts of the state.
Thank you. Does Healthy Maine Partnerships pay for nicotine patches or gum for patients who want to quit smoking and have Medicare as their insurance?
No, Healthy Maine Partnerships do not pay for patches. Through the Maine Tobacco Helpline, there are some services for medication like nicotine patches that are available if people meet the income eligibility criteria. So what I would encourage anyone who had that question, I don't know all the details about the eligibility, they could call the Maine Tobacco Helpline.
What is the typical age range that annual screening will or should begin occurring?
So the guidelines backed by the United States Preventive Services Task Force, as well as other professional organizations, started at age 55. And there's a little bit of wiggle room there among one of the guidelines in particular, but pretty much most of the other guidelines agree that starting at age 55. We are moving, and I'm not going to talk too much about this, but there's movement of the field towards what's known as risk-based screening to sort of get a little bit more precise to determine individuals' risk of lung cancer and tailor screening decisions to those individualized risks, but that has not been a widely accepted practice yet. So 55 is a beginning age.
Is there any data currently concerning secondhand smoker risk and screening?
Unfortunately not, although what I just mentioned, this idea of kind of risk-based screening, some people are advocating for that, including secondhand smoke as well as other risk factors into screening decisions. But as of now, that's not yet considered one of the criteria, for screening eligibility.
In addition to Medicare's eligibility criteria, they require physicians to take several extra steps beyond the criteria, things like shared decision tools and discussions they have to have with patients year after year. Does your plan address the extra steps that physicians will have to take?
Yes, it does. That's a major focus, and I'll again let Dr. Corson comment on that, but that's a major central focus of our mission.
So this is Neil again, and the Medicare criteria require a counseling visit that addresses the fact that while there are certainly benefits to screening with low-dose CT scan, there are also some potential risks. The evidence right now is that roughly 1 in 4 people who are screened will have something abnormal show up on their low-dose CT scan. It may be a minor abnormality that requires a CT to be done sooner than a year later, but it may be something that might lead to a recommendation for a biopsy or another type of invasive approach. We want to make sure that people understand these potential risks and the 1 in 4 possibility that something abnormal will show up, at the very least, may lead to some worry. So that's why this extra step of a shared decision-making visit. There's also the issue of tobacco, and that many of the people who were being screened are still smoking, and it's an opportunity to talk to them about their tobacco use and offer help.
So unfortunately, we are at the end of this session, and we have a couple more questions that we're going to pass along to the panelists here, and so that they can respond to it in the follow-up email. But we want to thank you all for joining us today, and we hope that you can join us for our next Lunch and Learn session, which is going to be held on June 20th. From 12 to 1, and it's on the cost of care conversations in the clinical visit, and the speaker is Dr. Peter Rubel. So thank you everyone for attending today, and stay tuned for an email tomorrow with the slides and the recording link.
Thank you.
Thank you. Have a great afternoon, everyone. Bye.